When you get a patient with hemolytic anemia, how to proceed? In this video, we're going to see if we have an initial assessment that suggests the patient has hemolytic anemia, what to do. You see, if the patient has low reticulocyte count, the LDH is high, the indirect bilirubin is high, this is probably intramedullary hemolysis. This intramedullary hemolysis may be because of B12 or folic acid deficiency. And then if we see the reticulocyte count is high, bilirubin is high, and LDH is high, we assess the patient or the family history is there for a past episode of hemolysis or anemia. It is there or it's not there. If the patient has a positive past family history or his own history of having hemolytic anemia or anemia, we should consider. If this anemia was triggered by an infection, oxidative stress, or the patient had neonatal jaundice, this may be acute, chronic, or episodic. Prepares the Heinz body slide, and this is possibly because of G6PD deficiency or sometimes pyruvate kinase deficiency. If the patient has gallstones, there's splenomegaly, spherocytes or elliptocytes, order a red cell fragility test. If this is positive, this is hereditary spherocytosis or elliptocytosis. Generally, these are benign conditions, particularly elliptocytosis. And if the patient has joint pain, hip necrosis, sickle cell and target cell, and also some of the patient may have skin ulcers, order for sickle cell preparation, hemoglobin electrophoresis, and hemoglobin A2 estimation. This possibly could be sickle cell disease or thalassemia. And if the patient with hemolytic anemia has high reticulocyte counts, high LDH, high bilirubin, and there is no past or no family history of hemolysis or anemia. If on peripheral film thrombocytopenia is there and there are schistocytes, look for TTP, that is thrombotic thrombocytopenic purpura, DIC, or hemolytic uremic syndrome. Some of these conditions may present acutely. Some of them may be a chronic type of diseases. Then, considering autoimmune hemolytic anemia, go for direct antiglobulin test and indirect antiglobulin test. That is a direct Coombs test and indirect Coombs test. If direct Coombs test is positive with a warm antibody, this possibly is because of chronic lymphatic leukemia, lymphomas, SLE, autoimmune disorders, connective tissue disorders. And then if this indirect Coombs positive, this is most likely alloimmunization. And then if cold agglutinin titer is high or cold agglutinin antibodies are present, this could be infectious mononucleosis, mycoplasma, or sometimes lymphoma as well. Then look for the presence of drug-induced immune hemolysis that can be seen on the history of the patient taking a drug which can cause hemolysis. And then if the patient has dark urine, there is low haptoglobin, abdominal pain, thrombosis, it is triggered by barbiturate, it may be episodic, it may be acute, chronic, get flow cytometry for CD55 and 59, flare test, rule out paroxysmal nocturnal hemoglobinuria. So this is how we proceed if we get a patient who's got hemolysis on initial assessment.